So, unique and cost-effective organism-based endophthalmitis prophylaxis in community eye care section. So, the aim of the study was to analyze the outcomes of different endophthalmitis prophylactic measures in cataract surgery between the years 2013 and 2021 in a community eye care section of a tertiary eye care hospital. This was a single-center retrospective study. So, all the patients who underwent cataract surgery in the community eye care section from 2013 to 2021 were included in the study. Combined procedures such as trabeculectomy or penetrating keratoplasty with cataract surgery were excluded. The data was obtained from the patient records. All patients underwent detailed eye examination with an AK as well as a scan preoperatively, and sac syringing was done whenever indicated. Preoperatively, the periocular area and conjunctival sac was prepared using topical povidone iodine solution, and majority of the cases were done using manual SICS, which is 85.1%, and the rest by phacoemulsification with implantation of a PMMA IOL. The surgeries were performed by consultants, registrars, fellows, as well as postgraduate residents, and the same sterilization techniques were adopted throughout the entire study. So from 2013 to 2015, the endophthalmitis prophylactic measure which was followed was tobramycin 0.1 ml in 500 milligrams of BSS. In 2015 to 2017, intracameral preservative-free moxifloxacin was used. From 2017 to 2021, 0.1 ml of amikacin 12.5%, which was added to every 500 milligrams of BSS was used, thereby achieving an effective concentration of 0.025%. So here, the dose of amikacin was based on calculations which was targeting an anterior chamber concentration of amikacin that would exceed the MIC of the susceptible bacteria. Here you can see 0.1 of amikacin withdrawn and injected into the 500 ml of BSS. So postoperatively on POD1, the eye patch was removed and replaced with goggles. The complete examination was done and patients were started on ofloxacin dexamethasone, which was tapered over 50 days. So we analyzed the records of patients diagnosed with postoperative endophthalmitis or sectional wound infiltrates presenting up to 8 weeks postoperatively. All patients underwent detailed microbiological examination. Statistics was done using the chi-square test. So coming on to the results, we divided them into 3 groups. The first group, which is the tobramycin group, around 15 cases of endophthalmitis were reported. The second being the moxifloxacin group, around 17 cases of endophthalmitis were reported. And the third one being the BSS with the amikacin group, around 10 cases of endophthalmitis was reported. A total overall of around 240,000 cataract surgeries were performed during the study period. So among the tobramycin group, among the 70,000 cases, 15 cases at postoperative endophthalmitis, where majority was culture negative, followed by gram-positive cocci, nocardia, as well as fungal infections. In intracameral moxifloxacin group, 17 cases of post-op endophthalmitis were reported. Majority again was culture negative, followed by gram-positive cocci as well as nocardia. Third, in the amikacin and BSS group, though 113,000 surgeries were performed, only 10 cases of post-operative endophthalmitis were reported, and culture negativity was 80%, followed by gram-positive cocci. So on comparison between the endophthalmitis rate of 3 groups, after introduction of amikacin, there was a significant reduction in the rate of endophthalmitis. Here you can see the p-value which is being significant on comparing the amikacin group with the toba group, as well as I'm comparing the amikacin group with the moxifloxacin group. Coming on to the microbiological analysis, there was no significant difference in the rates of culture negativity or gram-positive cocci among the 3 groups. However, there was a significant reduction in nocardia endophthalmitis in group 3 on comparison with the other groups. So here you can see gram stain, the beaded pattern on gram stain for nocardia, as well as sectional wound infiltrates with hyperpions seen in these post-op patients. So among the endophthalmitis cases, 14 cases had been performed by consultants and 14 each by residents and fellows, and only 1 of the 42 cases had undergone phacoemulsification and rest by scleral MSICS, and only 2 of the 43 cases of endophthalmitis had intraoperative complications, one being PCR and the other being a ZD with vitreous loss. Coming on to discussion, we all know the landmark study, which is the EVS study, which stated that gram-positive cocci was the most common organism. Lundstrom et al. Also did a comparative analysis and found that gram-positive cocci bacteria are more common when there was a communication with the vitreous, and gram-negative was more common in elderly patients. So keeping all this into consideration, the ACRS put down a guidelines of saying use intracameral cefuroxime 1 milligram in 0.1 ml. However, then we had the landmark trial by Haripriya et al., where they showed that the use of intracameral moxifloxacin brought down the endophthalmitis rate by almost 4-fold. But moving on to the literature review and seeing the causative organisms of endophthalmitis in India, you can see that the slow shift from gram-positive cocci to gram-negative organisms, as well as an increase in the nocardia species, especially in the south of India. So Prajna et al. Did the study and they found there was a high prevalence of nocardia endophthalmitis. However, they failed to find a solution for the same. So the microbiology of endophthalmitis in India is different from the ones reported in the EBS as well as the ESCRS studies. And latest studies have also shown that the irrigating solutions used intraoperatively were found to be the most common source of endophthalmitis. So use of amikacin in BSS could be an option when nocardia endophthalmitis is predominant. So amikacin, as we all know, it has good activity against gram-negative bacilli, against Acinetobacter as well as Pseudomonas, and it has got very good activity against nocardia and some Mycobacterium species. So what about the safety? So with this particular dose of amikacin, it was reported to have no endothelial toxicity or no macular toxicity, as evidenced on specular microscopy as well as OCT macula. And coming on to cost effectivity, one vial of amikacin cost only 35 rupees. So one vial of amikacin can be used for 20 bottles of BSS. Therefore, in a community eye care section, it becomes very cost effective. So conclusion, this is the first and the largest single center study to report comparative analysis of different endophthalmic prophylactic measures in a community eye care setup with high incidence of nocardia endophthalmitis. Introduction of amikacin in BSS is thus a unique, cost-effective and efficient prophylactic measure to prevent nocardia endophthalmitis. These are my references.